In the bustling environment of an Indian joint family, the piercing sound of a newborn crying instantly commands the attention of the entire household. It usually results in a flurry of advice, with every relative offering a different diagnosis. Families often assume the crying means the mother's breast milk is insufficient. This assumption creates immense psychological pressure and places a heavy, isolated burden on the new mother. Dr. Prashant categorizes these vocalizations as clinical symptoms rather than behavioral choices. Newborns lack the neurological maturity for manipulation or tantrums. The alarm sounds due to physiological imbalances, independent of the mother's milk supply or skill. This schematic shows a newborn's brainstem. Crying functions as an involuntary reflex originating right here. The infant's central nervous system is entirely immature, causing them to cry only when a physiological parameter, like dropping blood sugar or a change in skin temperature, falls out of balance. Because they cannot self-soothe or wait, their system triggers a massive release of adrenaline. This chemical flood forces the baby to vocalize their distress loudly enough to guarantee an adult will intervene and ensure their survival. It is a biological alarm. To quiet the room, households must replace cultural guesswork with clinical triage. This requires a systematic approach to diagnose and neutralize the specific physiological trigger. The first check is hunger. While hunger is the most common cause of crying, the panic associated with it often leads to unnecessary formula supplementation. We have to look at the biological timeline of this distress. Crying is a late, desperate sign of hunger. Long before the vocal alarm sounds, the baby's body issues subtle neurological cues. They will exhibit the rooting reflex, turning their head, opening their mouth, smack their lips, and suck on their own fists. This graph tracks early hunger cues against rising levels of cortisol, the stress hormone. If you wait for a full-throated cry, cortisol spikes so severely that it becomes mechanically impossible for the baby to coordinate their tongue and jaw to latch onto the breast. If the 2 to 3 hour feeding window is missed, forcing the feed will cause the baby to swallow air, leading to painful gastric distension. To resolve this, hold the baby upright against your chest and sway gently to lower the adrenaline levels before attempting the latch. The second check evaluates skin integrity. Traditional cotton lingots are highly breathable, but a newborn's protective outer skin layer, the stratum corneum, is incredibly thin and permeable. Here we see the infant's outer skin layer. When a baby voids, bacteria from the digestive tract immediately break down the urea in the urine into caustic ammonia. Prolonged exposure chemically burns the fragile skin. A wet cotton languet requires an immediate change within 10 to 15 minutes. The skin must be cleaned with plain water and thoroughly dried to prevent rapid tissue breakdown and severe diaper dermatitis. Both a missed feeding window and an ignored wet languet rapidly escalate minor biological needs into severe, excruciating physical pain. The third check is thermal distress. The deep-seated fear of pandilagjaegi often results in newborns being wrapped in multiple sweaters, woolen caps, and thick rizais, even when the room temperature is comfortable for adults. A newborn's thermal regulatory system is underdeveloped. They are at the mercy of their environment because they cannot shiver to generate heat or use sweat glands to cool down. The infant's core body temperature must remain between 36.5 and 37.5 degrees Celsius, or 97.7 to 99.5 degrees Fahrenheit. Pushing into the red zone causes metabolic heat stress. Severe overbundling directly leads to an elevated heart rate, dehydration, and the physical sensation of suffocation from trapped heat. The clinical rule for dressing is to use exactly 1 layer more than an adult requires. Judge their temperature by touching the back of their neck or chest, as their hands and feet are naturally cold. The fourth check is sensory overload. Indian joint families often involve bright tube lights, loud conversations, and the baby being passed between multiple relatives. Adult brains utilize sensory gating to filter out background noise. A newborn's brain lacks this mechanism, registering every sound and touch as a massive, unfiltered electrical impulse. Continuous active handling by multiple people must not exceed 45 consecutive minutes. Beyond this, the fragile nervous system will overload, resulting in an inconsolable meltdown. To resolve overstimulation, take the baby into a dark, quiet room with 0 visitors. Minimize eye contact and hold them tightly to allow their nervous system to systematically reset. Managing ambient heat and sensory input is a requirement for physiological survival, alongside feeding and hygiene. Most crying is resolved by checking hunger, wetness, temperature, and stimulation. However, there are times when these needs are met and the alarm will not turn off. Pay attention to the quality of the cry. A high-pitched, shrill, cat-like wail indicates severe neurological irritation or extreme pain. Monitor the duration carefully. If a baby cries inconsolably for more than 2 hours, despite all interventions, they require medical evaluation. A rectal or armpit temperature exceeding 38.0 degrees Celsius, or 100.4 degrees Fahrenheit, in any infant under 3 months of age is an acute medical emergency. Seek immediate care at an emergency room for a febrile, screaming newborn. This is necessary to rule out life-threatening bacterial infections, such as neonatal sepsis or meningitis. A newborn's cry is the only language they possess to ensure their survival. Approaching this signal with clinical precision allows the household to function as a medical team, securing the baby's physiological needs and the mother's peace of mind.